skeletal muscles, updated approach.
Bismillahirrahmanirrahim. First of all, I would like to thank the organizing committee for their invitation. I will talk about imaging with skeletal muscles, updated approach. The muscular system is one of the largest organ systems of the human body, accounts for about 60% of total protein stores. Skeletal muscle diseases encompass a huge and heterogeneous group of both hereditary and acquired disorders. The clinical presentation of these diseases may be quite similar. The diversity of muscular diseases signifies an important role for imaging in their detection and characterization. The imaging modalities commonly used for skeletal muscle imaging are MRI, CT, and ultrasound. Imaging of skeletal muscles include qualitative and quantitative techniques. Start with the MRI. MRI has excellent soft tissue contrast resolution with no ionizing radiation. It can readily assess the muscle size, shape, and signal intensity changes. Can detect selective abnormality within individual muscles that may be challenging to be detected clinically, but also it has some limitations. It has a long acquisition time, high cost, and may need anesthesia or contrast material. Also, some contraindications such as pacemakers. Muscle edema by MRI shows the low signal on T1 and high signal on T2 and fat suppressed images. Muscle fatty infiltration shows high signal on both T1 and T2 with signal drop on fat suppressed images. This is an example of muscle fatty infiltration of the thigh muscles. This is the T1 and the T2 and the stair images of fat suppressed images. The high signal in T1 and T2 and signal drop on fat suppressed images indicates fatty infiltration. While in muscle edema of the gluteal muscles, low signal may be not detected in T1, subtle high signal in T2, but in stair images or fat suppressed images, the high signal is well seen. CT, coming to CT is a quick, relatively inexpensive, and almost universally available, can assess muscle morphology and size, can detect muscle replacement by fat, and also detect calcifications or gases within the muscles, can guide muscle biopsy, but also it has some limitations. It's characterized by limited contrast resolution and involves exposure of the patient to ionizing radiation, which is a very important factor in pediatric age group. Both muscle edema and fatty infiltration cause decreased muscle attenuation on CT examination, but they can be differentiated by measuring the Hansfield unit. Causes of increased attenuation within the muscle on CT include calcifications, metallic foreign bodies, and fresh blood. Then an example of muscle fatty infiltration of the gluteal muscles, has the same CT density or to the subcutaneous fat, and this is an example of muscle edema in which there is areas of low attenuation within the muscles. Coming to ultrasound, it is a non-invasive, real-time, relatively inexpensive, and almost universally available, does not need anesthesia or contrast material, does not expose patients to ionizing radiation, can assess muscle morphology and size, can guide muscle biopsy, but is limited ability to assess deeper structure or deep structures, and it is operator dependent. Both muscle edema and fatty infiltration cause increased muscle heterogeneity on ultrasound examination. Ultrasound can differentiate between solid and cystic focal masses within the muscle. Doppler technique can assess the presence of active inflammation and the vascularity within focal masses. Then an example of fatty infiltration of the muscles of the thigh, increased heterogeneity with poor detection of the cortical surface of the bone, underlying bone. While in muscle edema, there is patchy hyperechoic areas as compared to the normal contralateral side. This is the normal muscle, contralateral muscle. This is the abnormal muscle with patchy hyperechoic areas due to muscle edema. Patterns can appear by imaging of skeletal muscles. The first pattern is muscle edema pattern. It occurs in acute or recent insult to muscles characterized by edema, vascular engorgement, and inflammatory cellular infiltrate. On MRI, muscle edema manifests as areas of low signal intensity on T1 and high signal on T2 and fat suppressed images. While in CT, muscle edema is shown by hypodensity, and ultrasound causes increased muscle heterogeneity. Causes of muscle edema pattern variable either traumatic, muscular exertion, rhabdomyolysis and myonecrosis, vascular insults, early myositis ossificans, subacute denervation, radiation therapy or radiation injury, and myositis, either autoimmune or idiopathic infectious. This is an example of muscle edema in infraspinatus muscle, in infraspinatus muscle strain. This is coronal fat suppressed images. This is muscle edema or soreness of the extensor carpi radialis brevis, also fat suppressed images with high signal intensity. Polymyositis, bilateral nearly symmetrical high signal intensity within the muscles, in T2 weighted images. Myositis of the psoas and pelvic girdle muscle, high signal intensity within the muscles, patchy. This is myositis of the masseter muscle following dental procedure by ultrasound and CT. CT shows areas of hypodensity as compared to the normal masseter muscle on the contralateral side. This is muscle is enlarged due to edema and low CT density within the muscle, and the ultrasound shows high echogenicity, increased echogenicity within the masseter muscle, which is seen to be swollen and enlarged. Myonecrosis with jazz within the muscle due to contaminated wound. This is a T2 with abscess or fluid collection seen within the muscle, and the jazz appears as low signal intensity on fast suppressed images and all bus sequences. شكرا. Another second pattern of muscle is a fatty infiltration pattern. It occurs in non-acute or chronic muscle insult, may result in dystrophic changes with abnormal fatty infiltration and muscular atrophy. On MRI, it appears as high signal on both T1 and T2 with signal drop on fat suppressed images. On CT, muscle fatty infiltration is shown by muscular hypodensity. On ultrasound, causes increased echogenicity. The causes of muscle fatty infiltration pattern include chronic stages of muscle injury or myotendinous junction injury, chronic disuse, chronic denervation, hereditary or acquired myopathies, use of corticosteroids, and normal aging. This is an example of a specific type of muscular dystrophy called sodium channel myotonia. There is fatty infiltration of all foot muscles with relative sparing or spared quadratus plantae muscle. Soleus and gastrocnemius muscle fatty infiltration in limb-girdle muscular dystrophy, high signal within the muscle. Disuse atrophic changes or fatty infiltration of the infraspinatus anterior minor muscles. Gluteal muscle fatty infiltration due to prolonged steroid intake in case of Crohn's disease. This is an example of ultrasound fatty infiltration in 12 years old child with Emery-Dreifuss muscular dystrophy compared with the normal age and sex matched control. This is the muscles with fatty infiltration shows increased echogenicity, while this is the normal appearance of muscles in this age. Third pattern is mass and mass-like lesion pattern. Implies the presence of space-occupying lesion within the muscle. The MR imaging characteristic of lesion produces a mass effect and variable and typically differs from those of normal muscle in all pulse sequences. Causes of mass and mass-like lesions pattern include infection such as byomyositis, abscess, parasitic infestation, myositis ossificans, or traumatic such as hematoma, myonecrosis, muscular sarcoidosis, primary benign or malignant neoplasm arising within the muscle such as lipoma, liposarcoma, and leiomyosarcoma, and soft tissue metastasis. Then an example of a psoas muscle abscess within the right psoas muscle. This is an abscess here as compared to the normal contralateral left psoas muscle. This is a contrast enhanced study with REM enhancement. Tibialis anterior muscle myositis ossificans, low signal on all pulse sequences due to presence of calcifications, myositis ossificans. Subacute hematoma within the vastus intermedius muscle. Piriformis muscle metastasis from soft tissue sarcoma. Coming to quantitative and semi-quantitative muscle imaging. Indications of quantitative and semi-quantitative muscle imaging include the diagnosis and monitoring of primary muscle diseases such as myopathies and muscular dystrophies, and secondary muscle affection in denervation, malnutrition, chronic obstructive pulmonary disorders, cancer-associated cachexia, diabetes, renal failure, cardiac failure, Cushing syndrome, sepsis, burns, and trauma. Two types of quantitative methods are used. The first type to measure or to quantify the muscle bulk. Several techniques have been developed to quantify muscle bulk. The most straightforward quantitative measurements are the muscle thickness and muscle area from a single slice, or muscle volume from a stack of slices covering the whole muscle. This is a case of Duchenne muscular dystrophies. This imaging as at diagnosis, and this row is 4 years later. If we look to the thigh muscles, the volume of the or bulk of the thigh muscle decreases with age, while those of the calf muscles, these two images, increases with pseudo-hypertrophy. This is a semi-quantitative appearance. But to quantify muscle volume for a selected muscle, we should do segmentation, either manually or automatic muscle segmentation, to measure the volume of every muscle, each muscle separately. Or by ultrasound, we can measure, standardize the site of imaging by ultrasound and measure the thickness of the muscle, either the whole thickness or the vastus intermedius alone and the rectus femoris alone. This is the subcutaneous tissues. Or can measure the cross-sectional area of the muscle within a specific site, can be used for follow-up of disease. The second topic to quantify with imaging is fatty infiltration in muscles. Lipids are either stored as adipocytes or as intramyocellular lipid droplets, called intramyocellular lipids. Adipocytes can be located subfacial between the muscle groups, called perimuscular adipose tissue, or as interstitial intramuscular adipose tissue within an individual muscle, called extramyocellular lipids. The combination of perimuscular adipose tissue and extramyocellular lipids correlate with cardiovascular risk, while the presence of intramyocellular lipids is a risk factor for insulin resistance. How to quantify the muscle fatty infiltration? Start with the semi-quantitative techniques. This is the mercury score for grading of the muscle fatty infiltration, can be applied for MRI and CT. Classify the muscles into 6 grades, starting with 0 grades, normal appearance, stage 1, few scattered small areas of decreased tissue density or increased T1 signal on MRI, given the early moth-eaten appearance. Stage 2A, late moth-eaten appearance with numerous discrete areas of decreased tissue density or high signal on T1 weighted images, but less than 30% of the volume of individual muscle. 2B, between 30 and 60% of the volume of the individual muscle. 3, confluent areas. And 4, the muscle is totally replaced by fat. In ultrasound, we use the Hikmat scoring for muscle fatty infiltration, classifying the muscle into 4 grades. Grade 1 is the normal one. This is the appearance. The muscle is hypoechoic, and the cortical surface of the underlying bone can be properly detected and well defined. In grade 2, increased muscle echogenicity with still distended the bone cortical surface, while in grade 3, the marked increase in the echogenicity and reduced bone echo, while in grade 4, the marked increase in muscle echogenicity with disappearance of the cortical surface of the bone. Coming to quantitative muscle imaging techniques, and starting with the Dixon sequence of the MRI, is one of the quantitative MRI sequences that quantify muscle fat replacement. It has been shown to be more sensitive than clinical evaluation of detecting disease progression. It also has the potential to be very valuable on outcome measure for clinical trials, especially in muscular dystrophies. This is the results of Dixon sequence. It gives us four images or 4 sequences: in phase, out of phase, fat only signal, and water only signal. and we can quantify the signal within an individual raw, individual muscle, for water-only images, for fat-only images, for opposed phase or in-phase sequences, and we can measure and follow up the disease progression. MR spectroscopy of the skeletal muscles can be used to assess muscle metabolism using the phosphorus 31 or carbon 13 to measure the concentration of high energy phosphates or muscle glycogen respectively. Also, we can use the conventional or the well-known MR spectroscopy by hydrogen 1 to assess the muscle lipids composition. Then an example of case of muscle fatty infiltration. Here, this is the sequence. The MR spectroscopy of the diseased muscle show low signal for phosphorus, denoting less active muscle, while in conventional MR spectroscopy, high lipid peak due to fatty infiltration. T2 mapping. In T2 mapping, skeletal muscle edema can be caused by trauma, early myositis, ossificans, and inflammatory myopathies. Edema results in increased T2 relaxation time, and it is an indicator of inflammatory process which often proceed to replacement by muscle fatty infiltration and replacement by adipose tissue. This is a T2 map and follow up after steroid therapy. This is the initial, and this is after steroid therapy, denoting decreased T2 relaxation time indicates improvement of the disease process. In diffusion weighted images and diffusion tensor imaging, diffusion weighted image sequence is used to examine muscle to identify muscle edema, radiation injury, inflammatory and neoplastic lesions, while in DTI it is a relatively recent imaging technology, provides quantitative information about the water diffusion process within the imaged anatomical region by measuring diffusion in several directions. It allows in vivo assessment of muscle fiber integrity. In dermatomyositis, the diffusion is restricted and the high signal in diffusion weighted images, and this is the maps we can acquire with diffusion tensor imaging, MED and FE maps. Quantitative muscle by CT to assess the muscle density by CT requires a calibration step with a properly calibrated CT scanner. The CT density of skeletal muscles between 50 and 60 Hansfield unit. Infiltration of extracellular lipids or adipose tissue within the muscle will decrease the CT density below 50. This is the phantom used to calibrate the CT scanners, and this is the histogram of CT density of individual muscle. Quantitative muscle ultrasound, we can use the ultrasound to measure the brightness of the muscle, indication of fatty infiltration. We obtain a number of the indicates the brightness of this muscle. The key points: skeletal muscle disease are a heterogeneous group and many of them share nearly the same clinical picture. Imaging is an essential part of the diagnostic workup of these diseases and also to monitor their progress and response to treatments. The proper choice of the best imaging modality needs efficient communication and cooperation between the radiologist and the physician as a MDT. Thank you.
Professor Hossam, طبعا very impressive presentation. Thank you very much for your effort. Next speaker is Dr. Nayera Ibrahim.